high-risk smoldering myeloma has been on the table for quite a few years at this time. People are arguing back and forth whether you need to treat it or not treat it. I have been involved in developing many different investigator-initiated studies in this setting. I've used antibodies, NK cell triggering antibodies. We have used combination therapies. We used DARA therapy, single drug. The combinations we have used is KOD. We have also used other types of combinations. And we are working on other protocols as well. What we have always been thinking about in our group is what is really the biology in these patients? Do patients that go on the trials really have the biology of progressing into myeloma? Is the disease equally developed compared to a newly diagnosed patient? And I think it really raises in our head many questions beyond just showing that you have deep responses. When is the right time to initiate therapy? Should we think about having biomarkers trying to identify the biological definition or the genomic definition of myeloma instead of waiting for symptoms to occur? We used the original phase 2 study that was developed at the NCI. I wrote this protocol back in 2010. We treated almost 55 patients with high-risk smoldering myeloma with KOD regimen for 8 cycles and then 2 years of lenalidomide maintenance. What we showed was that we had a very high rate of MOD negativity. We have published this in the initial results. We also had a follow-up study in 2021 in Immuno-Oncology. And at this ASH meeting, we had 2 presentations around this study. One of the presentations showed on the clinical side that at 8 years of follow-up, 70% of patients, they have a sustained MOD negativity. And this is after 8 cycles of KOD and 2 years of lenalidomide maintenance. So that's actually quite remarkable. In the second study, we used the baseline samples. We conducted whole genome sequencing. We profiled the disease for each and every person, and we studied how that disease correlated with clinical outcomes. We also compared it to baseline samples from patients that are newly diagnosed with myeloma. And in a nutshell, what we see is that overall, the high-risk smoldering myeloma patients have much less genomically evolved disease compared to newly diagnosed patients. So that raises the question whether the treatment should be started earlier than we currently do when we wait for patients to develop symptoms. Maybe that's the way to do it. But the other way of thinking about it is that the fact that you see less evolved disease and the cases that did progress, there are some few cases that did progress, they have more evolved disease. Could it potentially be that patients that don't progress maybe would not have progressed even without therapy? And that's obviously a question we will not be able to answer in this study. I have a feeling that looking at the clinical workup for these patients, that probably the disease is less genomically evolved at baseline, and thinking about developing genomic definition for myeloma or biological definition is probably the way to go. So earlier detection and earlier initiation of therapy with the intent to eradicate the disease. So this is interesting, and we keep on developing new studies, and we keep on dissecting the biology of the disease. So stay tuned on that as well.